Hi, everybody. It's a pleasure to welcome everyone to our first Zoom Saving Young Lives conference. It's a fabulous turnout we've had. We've had over 75 participants, nurses, physicians, trainees, and we have representatives from 21 countries, which is really quite incredible. So thanks very much for everyone joining. Let me start by first introducing everyone to the Saving Young Lives project. SYL was originally formed in 2012 and is run now as a joint venture between the ISN, the ISPD, IPNA, and EuroPD. The purpose is to provide educational support for the treatment of patients with acute kidney injury with a focus on peritoneal dialysis for those patients who need renal replacement therapy. The program now has been running, as I said, since 2012. We set up programs in countries in South Asia, Southeast Asia, and Africa, and have treated really upwards of 1,000 patients now with peritoneal dialysis and patients with acute kidney injury. And success rates have really been very good. So it's a pleasure to welcome everybody. This is really our first Zoom conference. We've had previous in-person conferences in South Africa and India, and those conferences have always been very successful. So we welcome everybody to the conference today. The format today will be, we're gonna have 3 lectures. The first lecture will be on acute kidney injury, pathogenesis, and treatment by Minion McCullough. The second lecture will be by Peter Norse, which will be updating the peritoneal dialysis acute kidney injury guidelines. These were originally published in 2014 in PDI and posted on the ISPD website, but they've been updated recently, and these have just been again published in PDI and again on the ISPD website. And the third lecture will be by Brett Cullis, who will update the guidelines for adult patients. And after the lectures, after the discussion groups, will regroup at the end for a 10-minute wrap-up session. So with that introduction, let's get started. And again, it's a pleasure to welcome everybody to this first Zoom conference for the SYL team. Thank you.
Good afternoon, everybody, or good evening, wherever you are. My name is Minion McCullough, and I'm going to be kicking off this afternoon looking at acute kidney injury in children, but I'm going to include some adult stuff as well. So I come from the Red Cross War Memorial Children's Hospital, and I'd like to acknowledge all my colleagues, both my nephrology colleagues as well as the ICU colleagues, and I'm very fortunate to be working with Peter Norse. So how common is AKI in the ICU? It's pretty common. If you look at many papers, there's varying amounts of incidents, and one of the big papers looking at 1,800 patients showed that 57% had AKI. And if you break them up into different stages, stage 1, stage 2, and 3, you can see that it is pretty common throughout, and it can be adjusted in terms of severity. So most of us these days would use the KDIGO guidelines. And if you look at that, the 2012 KDIGO guidelines shows that the clinical practice guidelines for AKI suggest using CROT over intermittent hemodialysis because of increased hemodynamic stability, better overall solute clearance, and better fluid balance. And it suggests high rates of renal recovery. We're also going to be speaking about peritoneal dialysis as a form of continuous renal replacement therapy today. Looking at the staging, if we're going to be using the KDIGO guidelines, there are 2 columns. One is the easier one, the urine output on the right-hand side, looking at less than 0.5 mils per kilo over 6 to 12 hours, over more than 12 hours and more than 24 hours. And then looking at the serum creatinine, looking at 3 stages. The problem, of course, is looking and seeing what your baseline creatinine is. So if you don't have a baseline, it makes it very difficult until you do have a baseline. And so this can be a little bit of a challenge. So that's why on the right-hand side, the urine output is a lot easier to monitor in the first 24 hours. But once you've got a baseline creatinine, you can then use that to decide if it's 1.5 times, 2 times, or even 3 times normal. So this has been described not just in young adults, but also in children. And it used to be called acute renal failure. We now call it AKI. There's fluid-related shock and sepsis is some of the commonest in children. Drug toxicity, specifically your aminoglycosides where there's no monitoring. In many cases, people would be giving frusemide and keep their fingers crossed and hope for the best. What causes AKI in a lot of these children? Well, it's often public health related, and we still see quite a lot of this: clean water, diarrhea, vomiting, and sepsis. And in children, at any rate, there's no really easy dialysis. There may be easy dialysis in adults, but not so much in children. So there's also been a modified P rifle, which is very similar. Just also looking at your urine output and your creatinine clearance. And I'm going to show you your creatinine clearance. There's this formula, which I'm going to concentrate on a little bit later. So just an example, we have at the Red Cross Children's Hospital 30 bedded ICU and neonatal high care, and pretty much standardly we have 1,400 admissions per year, mainly medical, but also cardiac, burns, head injury. Our mortality is predicted at about 10 to 12%. Realistically, its range is somewhere between 6 and 8. And our dialysis rate is about 3.5, but this does not include all the AKI. So causes of AKI: sepsis, we do a lot of cardiac surgery, but also undiagnosed chronic renal disease, gastro, HUS, or necrotizing enterocolitis. And then less commonly these days, the oncology cases, myocarditis. We do get the odd rapidly progressive post-strep nephritis, trauma, toxin, and then kwashiorkor. I've put 2 stars next to it because when somebody comes in with multi-organ failure and they've got kwashiorkor, on the whole, they don't do very well, and their mortality rate has usually been 100%. So these are kids that we wouldn't dialyze very easily. So I mentioned earlier that I would actually show you a formula, and this is the only formula I'm going to ask you to remember because children come in different sizes. So importantly, to try and get a height. So if you're a baby or a bigger child, then I'm going to use a height of 100 centimeters. If your creatinine is 100, which most people would not think is very high, and your constant is 40, so 40 times 100 centimeters divided by creatinine of 100 gives you a GFR of only 40. So we try and aim for a GFR of somewhere between 80 and 120. To parents, we say you'd want to get 100% marks at school. So if you've got a GFR of only 40, that's pretty bad. And so that just gives you an idea of what your GFR is in children of various sizes, because just using a creatinine is not very easy depending on their height. So Stuart Goldstein is known as the sort of pediatric intensive care nephrologist, and he says AKI happens when your urine output is less than 0.5 moles per kilo per hour for 6 hours. The AWARE study is looking at a lot of neonates as well, looking at severe AKI. Their odds ratio of death was pretty high, and he feels that when you have the rifle score, even when you have renal impairment, at that point already you need to start be worrying about morbidity and mortality. He's done quite a lot of interesting work using biomarkers and specifically NGAL. And he's always suggested that if you could come in with kidney pain into your casualty, like somebody who has cardiac pain and cardiac angina, maybe we would sit up and take more notice. And so in this publication, which is now already about 10 years old, he suggested this concept of renal angina, which is a risk factor in ICU admissions, stem cell transplants, those who've been ventilated and need inotropes. And so he's actually done a very nice scoring system. And he's also used NGAL together with this angina index. And I'm going to start off on the left. You get admitted to ICU. You have a renal angina score. If it's high, you then have a urine NGAL. You can then move on to a frusemide stress test. And if you then run into further trouble, you'd want to fluid restrict. And once you are more than 10 or 15% fluid overloaded, you would want to start renal replacement therapy. If your renal angina score is low, you would just go standard management and then continue watching and maybe giving diuretics if you need that. And in a similar way, you can also use your NGAL at the top. If that is high and your renal angina score is high, so just 2 parameters that you're looking at, that will already give you indication that those patients are in a lot of trouble and may need renal replacement therapy sooner rather than later. So quite an interesting scheme. We also then look at neonates, because this is particularly looking at children and young adults. But what about neonates? And I asked Breast earlier, how many of you guys sitting out there are pediatricians and have to look after newborns? And there are quite a few of you. So there's again also a neonatal AKI definition. Again, urine output, okay, but here, if your urine output is less than 0.3 moles per kilo for more than 24 hours, you know you're in trouble. Similarly, looking at your rise in creatinine. So very similar to the adult or the pediatric AKI score, but important to keep an eye on both your creatinine and your urine output. And then looking at the AWAKEN trial, this was a trial looking specifically at your neonatal AKI, looking at different gestational ages. So looking at the tiny prems, 22 to 29 weeks, looking at your 29 to 36 weeks, and looking at kids over 36 weeks. Many of you do look after neonates. And if I were to ask you, what are the risks for AKI in neonates? A low birth weight, less than 1.5 kilos would be one. Somebody who is term or not necessarily low birth weight, but has a low APGAR score, those kids who get drugs, and we know that non-steroidals are used for patent ductus arteriosus closure, so any kid who's got a cardiac issue. In fact, any neonate who's on mechanical ventilation, needing cardiac surgery, and in high-income countries, any neonate who needs ECMO. So those are big risk factors for AKI in neonates. I just wanted to show you this paper, which showed that 87% of a group of very low birth weight infants who were studied had at least between 1.6 and 2 medications which were nephrotoxic, and their AKI rate was 26%, and many of the children who developed AKI in this group of very tiny neonates actually ended up dying from renal failure. So therapeutic options to treat AKI in very prem babies, it's often very limited because they're very small. So if you're only 1 kilogram, it's really difficult. And so your renal replacement therapy may not be easily feasible. In infants and young children, the preferred choice would be peritoneal dialysis, but this is not always possible. And in our ICU in the last 2 weeks, we've had 2 children who've had abdominal surgery, and they've needed to go on to CVVH. And that is often very technically tricky because of the sizes of the lines and also the sizes of the children. So we are pushing boundaries more and more in neonates. So here's a child who had a urea cycle defect, who received a central line. This is a 5 French, so pretty small line, but big enough to do dialysis on, had hemodialysis to clear the ammonia, and then went on to CVVH. But this needs a lot of input and a lot of staff. We've also been working a little bit with a Carpe Diem, which is a neonatal AKI machine. You can see this is one of those machines where when you get it going, you call a lot of friends. And so it's taken us quite a long time to get familiar with this machine. And this is really not easily feasible in many centers, specifically in Africa and low middle income countries. Moving on to chronic hemo and transplants, so often you would need an adult unit which has established hemodialysis and transplant before you'd get a child. And in many countries in Africa, these children would need to be referred to places like India, where they would actually need to have their surgery before moving back. So at the end of the day, you don't want to get to chronic kidney disease. You want to actually stop your acute kidney injury so that you don't go on to needing dialysis long-term and transplantation. So prevention is better than cure. Lots of papers now saying that there's non-dialytic management of AKI in newborns. Most of you who've grown up in Africa would know about the study from 2011, the FEAST trial by Catherine Maitland, who looked at fluid boluses increasing a 48-hour mortality in critically ill kids. So too much fluid resulted in the death of these kids. And Jean-Louis Vincent, one of the critical care doctors, has said, maybe we would think differently if fluid was considered as an intravenous drug. Would we maybe dose patients differently instead of just giving them lots and lots of fluid? And so the WHO, following the increased mortality with the FEAST trial, has actually changed their fluid management in children with signs of impaired circulation. And they said if there's no signs of shock, there's a lot of evidence that you should not be giving a lot of fluid replacement. And that evidence is strong and it's high. So before we say, let's throw the baby out with the bathwater and don't give any fluid, how much fluid is okay? And going back to Stuart Goldstein again, he's done a really nice, easy formula, which basically just looks at the percentage fluid overload from the time of admission to the time when your child ends up needing chronic renal replacement therapy. And so more than 20% is suggestive that you're going to get into trouble. It's quite easy for us to do. You weigh the baby on admission, and then on a daily basis, you measure the fluid in and the fluid out. And this will give you some idea of how fluid overloaded you are. So just to show you fluid management, in the beginning in the green bar, we're going to be resuscitating with lots of fluid. And then the trick is in the blue bar, when you're doing maintenance or homeostasis, not to give too much fluid, because otherwise you're going to be spending the rest of that patient's ICU or high care stay removing the fluid. So fluid is okay for resuscitation, but after that, we need to have a look and make sure we don't overload the patient. So conservative therapy, don't allow fluid overload. We do believe frusemide has a role either as a bolus or as an infusion. Interestingly, aminophylline is making a comeback with either a single dose or 6 hourly doses. We tend to use that quite a bit. And to try and avoid your nephrotoxic agents, for example, gentamicin, but also ibuprofen, which a lot of GPs advise as the sort of pediatrician's choice for getting rid of fever. So clinical cases, we've got a congenital heart. We've also got a child who had birth asphyxia. One has no urine output, the other one has a high potassium. But just to show you, you can see that anybody could diagnose these patients. They've got a lot of fluid overload. Look at their potassium running at 7.5. Look at the ECG changes. I'm not sure if that's the physician's ECG or the patient, but you can see with treatment that potassium came down to less than 5. The treatment we use is potassium shifting. We use 10% calcium gluconate. We'd also use sodium bicarb to stabilize the myocardium. We may actually use frusemide at 1 milligram per kilo. Salbutamol nebs, these are easy to get. Intravenous salbutamol more difficult. K-exolate seems to get negative press at the moment because of colonic perforation, both in children and in adults. So just watch for that. And then insulin and dextrose, we're always a bit nervous to give children insulin because often their glucose drop and nobody actually is keeping an eye on that. So interestingly, a paper from Rosine Davids, which is from Cape Town, suggested that if you just give intravenous glucose without insulin, the patient's own insulin drive will decrease the hyperkalemia. So they feel even in adults, glucose-only bolus causes significant decrease in serum calcium. And I think that's quite a good teaching point, that insulin is without its issues. And then back to basics, insert a urinary catheter. So you may not have urine output because your child may be on, or your adult may be on morphine with urinary retention. It's always useful to get a history where there's been an antenatal scan if it's a neonate. And in an ICU setting, we now have ultrasounds as point of care. Important to look at the kidneys. Are they dilated? What are the kidney sizes? But also to look if the bladder is full or empty with a bedside ultrasound. And then just looking at when you've actually tried to treat them conservatively, as we've mentioned, you then have some absolute indications. So in young people, hyperkalemia, acidosis, and volume overload. We don't see much clinical uremia in kids. And relative indications, metabolic or liver failure, or in some cases, temperature control. So this is just a scheme showing that we would on the whole be using continuous renal replacement therapy, and I've put PD as that, and I know Pete's going to be speaking on continuous PD as your renal replacement therapy of choice. SCUF or SLED is also used. Intermittent hemo is less useful in an ICU setting or an acute kidney injury setting, even in the high care facility. So Saving Young Lives program, Fred and Brett have introduced it. Really exciting group of people working together with ISN, IPNA, EuroPD, and EuroPD. And you can see this was just before COVID hit us in February last year. It was one of our last Saving Young Lives in-person programs. Very exciting. When we could still meet in person, we hope to go back to that. We do a skills workshop at the Red Cross Children's Hospital. And these are pictures of where some of you work and how you've actually been rolling out the Saving Young Lives program into your regions, looking at using peritoneal dialysis as a form of renal replacement therapy. Many, many lives have been saved and the numbers keep going up, and we've trained just under 300 people now. And so my take-home message is that AKI is common in pediatrics, in neonates, but also in adults. Prevention is your first priority. And everybody with AKI not responding to conservative therapy should have access to at least acute PD. And specifically neonates are a group which can be quite a challenge. And so follow up on AKI, this is something that we are wanting to do long-term in our ICU and in our renal unit, look at what happened to those kids in terms of long-term follow-up. But at the moment, people are just concentrating on acute kidney injury. So I just want to say thank you for listening to this topic, and I hope this sets the tone for the rest of the presentations, and we'll see you in the chat groups. And I'm organizing a congress next year related to pediatric transplant. I can't end this talk without inviting you all to come to that. So thank you very much.
Right. Hello, everyone. Minnie and I work together at Red Cross Hospital. This is a different view than one she showed you. And as you can see, we do about almost 30 cases of dialysis, acute dialysis a year. And we tend to do acute PD first. So is PD still a popular modality in children? This is a survey by Rupesh Raina from 2017, which looked at North American countries and also at a whole lot of Asian countries, and just looking at what modalities are available and what is used. As you can see here, in developing countries, North American countries, although PD is hardly ever used, so only 5% of the time, where in developing countries, PD is used up to 68% of the time. And these are more or less mainly Asian countries. And when it comes to older children, then PD is used almost equally in developing and developed countries. And interestingly enough, even in the CRRT is actually not used that much in developing countries, and HD was actually the most popular modality here. This is quite different from a European survey, which was done in 2019, 35 centers, and this showed that actually PD and CRRT are the most popular modalities used, around about 40% each, and HD less so. This is a study from looking at acute kidney injury in children and adults in sub-Saharan Africa and systematic review. And in these studies, still most of the patients, the children, were treated with PD, although this is slightly different from a previous era. This is obviously not a survey, but just the studies that were published. So why is PD suitable? Well, it's got a long track record. If you look back, you find reports from 1949. It's less technologically demanding. It's cheaper. It's safe in cardiovascular instability, and it's been shown to be so. And it can be rapidly and safely instituted at the bedside with catheters. It's also useful, very useful in small babies. So we're talking about very low birth weight or low birth weight. So you're talking about under 1,500 grams babies. It's very useful, as you can't get a very good cardiac central venous access. Also, post-cardiac surgery is often the dialysis modality of choice, even in developed countries where they have all the bells and whistles. If children have coagulation problems, this is often useful, as you don't have to worry about bleeding. And one of the useful things is that when you're giving glucose in the belly with peritoneal dialysis, you can often restrict small babies right down to very low fluid input without worrying about them becoming hypoglycemic. One of the reasons we lucky in children is that the peritoneum is a better dialyzer than adults because of the increased peritoneal surface area relative to body weight. And also it's been shown that there's increased capillary density, especially in children less than 1 year. So we've actually got a better dialyzer available than in adults. So what about outcome modality? Well, the problem with this, there's a lot of the studies, there's been no standardized definition of AKI for a long time. The indication to prescribe a modality is often dependent on local expertise, availability, and clinical status of the patient, and often changing modalities in the same patient. There's often a paucity of patients for prospective studies, and there are ethical issues around randomized control trials. So if you just look around the world, you can see the survival of peritoneal dialysis varies markedly from one country to another, from 17 to up to 60% in different places. these are obviously not comparing apples with apples, so difficult to really get much idea about that. In CRRT, the mortality is more or less the same. It hasn't changed for a long time, but the patients are probably much sicker now than they used to be. So again, this is also very hard to compare one modality with other. In the few studies where they actually have compared patients, you can see that in the two patients where there was a comparing retrospective reviews where they're comparing modality, actually the HD patients had the best survival. This is and this is actually, if you read the studies, this is because the patients who had HD were the sickest patients on high inotrope scores and were the most sick patients. So again, in these studies, CRRT and PD actually had equal survival. So basically, retrospective studies comparing different dialysis modalities are affected by the choice of modality according to the severity of the illness and the characteristics of the patients. This is quite an interesting study from India where they looked at a retrospective view comparing patients who received HD compared to PD. And what they found here was the risk of death was 75% higher in the patients receiving HD after multivariate analysis. But what was interesting is that most deaths actually occurred either during hemodialysis or shortly after dialysis. And I think this is a very important message that if you haven't got the right equipment to do hemodialysis, then it's actually can be very dangerous. And in that situation, PD is often a much better choice. So often some units will have just adult equipment available, and this will be attempted to do HD on small children, which is not a good idea. When you look at the adult data, which Brett will probably talk about, but there's actually not much difference in mortality in the adult data either. So in summary, peritoneal dialysis is a suitable renal replacement therapy modality for children with acute kidney injury in children. And the choice of dialysis basically depends on local expertise, available resources, and the patient's clinical status. What about peritoneal access? So again, in the guidelines, this is a 1B recommendation for surgical tank-off catheters, and this is based mainly on old studies comparing, retrospective studies comparing tank-off catheters with bedside-placed catheters. However, they do come at a cost and also access to theatre. These catheters can either be placed open surgical technique or laparoscopic technique, or placed by the cardiac surgeon during cardiac surgery, and all these techniques have been shown to be good. We've got a recommendation that a perfectly acceptable alternative to surgically placed catheters is bedside placed catheters using a Seldinger technique. And these are either the old common Cook catheters that we're used to, or slightly newer, the multi-purpose Cook catheters, which can be used for chest drains, amongst other things, as well as dialysis. And the nice thing about them is they come in a number of sizes. So 5, 6, 8, 10, and 12 French catheters. And these have been shown in one retrospective review comparing them to tank-off catheters to be equally effective. Tank-off catheters can also be placed at the bedside, and this can be either with a Seldinger technique, either tunneled or non-tunneled technique. And this is also perfectly acceptable where. So the thing about these, you can place them very quickly. Up in 20 minutes, you can actually treat a child. You can see how babies being treated with those two types of catheters in our ICU. If you're going to put a catheter in, we've made quite a lot of some advance about this in the guidelines, that you really do need sterile technique. One of the things that puts people off PD is the high infection rate. But actually, if you dress up like this and make sure you open all the bags that you're going to be using to infuse fluid into the abdomen on the tray, you can definitely decrease infection. We also recommend, mainly based on the adult, on the chronic peritoneal dialysis guidelines, to give prophylactic antibiotics 6 minutes before, and this is mainly to cover gram-positive organisms. The rigid style catheters, these are available, and I know they're used quite a lot in Asian countries, but the recommendation is that these are not to be used unless you don't have soft catheters available. They save lives, definitely, but there's definitely a higher risk of leak, peritonitis, and viscous organ damage in the abdomen, and definitely should probably not use them longer than 2 to 3 days. This is a catheter. This is an intercostal drain used in Nigeria by Chris Esesabo, which he's published a few years ago. And although there's no sort of comparative data with these catheters, they definitely save lives, and this is something that can be used if you have nothing else available. As far as delivery systems go, it's very important if you're doing manual dialysis to have Buretrol so that you can measure the input and the output very carefully. This is generally in children less than 5 years of age, and it should be a closed system. And that's based on more chronic dialysis experience. There are a number of systems available now. So Fresenius has one, Baxter has one, there's one in the US that they also use. So we tend to use the Fresenius one. That's what's available. Improvised systems are also not recommended unless you have absolutely nothing else. And you can use, we used to use these. So we used to use make systems with Buretrols, three-way taps and lines, and these can be used quite effectively and if you're very careful, you can keep the infection rate down as well. What about automated systems? So this has a lot of advantages, less intensive nursing. It comes at a cost, but there may also be dead space problems. So we don't recommend that you use automated systems unless the full volume is more than 100 mils. And the prescription is the same as manual, and the two options available are the home choice and the Fresenius system. What about fluids? So there are commercially fluids available, and we use the same fluids as for chronic dialysis. We generally start with 2.5%, but it's depending on the clinical situation. Lactate-based fluids can be used very effectively. We have given a recommendation that if there is liver dysfunction or non-correcting acidosis or hemodynamic instability, then because the liver struggles to convert lactate to bicarbonate, that bicarbonate-based fluids can be used if they're available. We generally add potassium once the blood potassium is less than 4 millimoles per liter. And if you're not able to measure electrolytes, then after 12 hours of doing continuous peritoneal dialysis, we recommend that you add potassium to the bags anyway. We often add heparin to the bags, whether or not before on spec. And if there's hyponatremia, this is not also based on much evidence, we add sodium to the peritoneal dialysis fluid to keep it within 15 millimoles of the blood sodium. This is just to remind you that you can make hospital-made fluids by using intravenous fluids and just by adding sugar to the correct amount, because a lot of these intravenous fluids have very similar concentrations to the dialysis fluids, which you can see at the bottom here, compared to the top rows, which are the dialysis fluids. So this is got a 1C recommendation, and this is not recommended unless you don't have commercially based fluids. The prescription, there hasn't been much change in this, so we still recommend a full volume of 10 to 20 mils per kilogram, which may go up to 30 to 40 or 800 to 1,100 mils per meter squared to full volume. Cycles are usually 1 to 10 minutes, so you go slowly initially just to make sure there's no effect on ventilation, but once you've actually established that there's not too much effect on ventilation, you can go faster. Withdrawal is for 40 to 60 minutes, and the drain is for 20 minutes, especially with this. This can be reduced as necessary, but we do find with the small catheters, you need a 20-minute drain, otherwise you do not get the ultrafiltration. The neonates probably need shorter withdrawals, but there's not good evidence on this, and I'll speak about this a bit later. And we usually do peritoneal dialysis continuously for 24 hours for the first 1 to 3 days. So in the new guidelines, we've actually we've introduced some complications and troubleshooting of problems that can arise with the QPD. So as a table, there's a chapter on complications. So what happens if you've got a blocked catheter? And I'm talking mainly about the Seldinger-placed catheters here. First of all, you just make sure the bladder and the bowel are empty, so this is not causing the catheter to obstruct. Flush the catheter with heparinized saline. If a fibrin clot is suspected, there's some data that you can use tissue plasminogen activator. And this is mixed in 10 mils of saline and injected into the volume of the catheter and left for 1 hour and then removed. If that doesn't work, you can replace the catheter over guideline in the same position. And if that's still not working, then you need to insert a new catheter in a different position. What happens if you have a pericatheter leak? First is you can try and reduce the full volumes if this is possible. You can should a period of time off dialysis, in other words, burst continuous for 24 hours, in addition to a reduction in the full volumes. The next step is to replace the catheter over guide wire in the same position with a larger gauge catheter. And this is where the multi-purpose Cook catheters are very useful. As you saw, they came in a number of different sizes. So if you're using a 6, you could actually try and replace it with an 8 French catheter. There is some evidence in the chronic dialysis literature, but actually also in this one study in acute dialysis, that you can use fibrin glue between the catheter and the tunnel. And we have used this a number of times. Just got to be careful when you're actually then removing the catheter again, just to be careful. You can also insert a catheter in a new position. If you have low ultrafiltration, the first thing is normal, rule out access issues or peritoneal leak. You can increase the glucose concentration. You can increase exchange frequency by reducing the dwell time by plus minus 25%, and reduce the fill and drainage times as much as you can. If that's still not working, and increase the full volumes to 30 to 40 mils per kilogram. And one thing you can do is consider continuous flow peritoneal dialysis, and there's a description of this in the guidelines. What about dialysis dose? So the dialysis, the adult recommendations are that we target a weekly KTV of 2.2, and this has been shown to be equivalent to higher doses. And there are no pediatric studies correlating dose to outcome parameters in acute PD, therefore there are no target clearances can be set. And the problem is we're using quite small full volumes, at 20 mils per kilograms. But in the studies that have actually measured clearance, and those on the right there, you can see that we've managed to get a KCOV of 4.84, even with the small volumes and full volumes and fast dwell cycles. So probably what we're using is good enough. This is a study we did a few years ago using the BM25 CVH machine to circulate fluid through the abdomen and doing continuous flow peritoneal dialysis, so that you fill the patient with some fluid, 20 mils per kilo, and then you circulate the fluid through the abdomen. And this was, in this study, we shown that the ultrafiltration and the clearance rates were up to 3 to 4 times higher using this technique. We have now been trying to do this with gravity because the pumps are expensive and we'd like to make this available to everyone. So we've been doing some studies with gravity-assisted CFPD and actually showing using a full flow rate of 50 mils per 1.73 meters squared, getting quite improved ultrafiltration and clearance. And so this is hopefully the study will be finished soon. What about a pleural effusion? Well, this is a relative contraindication, we think. It often happens in cardiac patients when you're doing a stenotomy. There's a high incidence, and also because of the way they put the catheters in, they often breach the diaphragm. So if there's no other options available, we usually leave the catheter, and we put a chest drain and test for glucose to confirm that it is peritoneal dialysis fluid. And then we actually just include the drainage from the catheter in the fluid balance. So, and we've actually managed to dialyze a number of patients quite successfully like this for a number of days. So what happens if you, I can't actually see the top there, but if you insert the catheter into an organ in the patient, and so if you put the catheter either into the bowel or into the bladder, this will manifest by either fluid via the urethra or diarrhea when filling the abdomen. In this case, we recommend a surgical opinion should be sought in suspected cases. If bowel injury is suspected, but there are not clinical signs of peritonitis, then you need to closely monitor the patients for peritonitis, and you should add antibiotics to cover for presumed intra-abdominal sepsis. So this would be something like either augmentin or ertapenem or meropenem would be good choices for this. And if PD is still necessary and the surgeons have excluded the need for surgical repair, then a new catheter can be inserted and the PD can commence. And we have often done this and successfully carried on with dialysis. What about peritonitis? Well, the rate varies from 44 to 80%. This is why we're going on about peritonitis. But the management is as per chronic peritoneal dialysis guidelines because there's not really good evidence in acute PD. Just remember the peritonitis can be masked by the patient's overall illness. So we tend to send leukocyte counts every 1 to 3 days. And there's some data using leukocyte esterase sticks daily to screen for peritonitis in acute PD. You also just need to remember to have a high index of suspicion for fungal peritonitis in the ICU. What about intra-abdominal pressure? So PICU recommendations are that intra-abdominal pressure be measured in patients at risk of abdominal compartment syndrome. And in fact, one of the risk factors is peritoneal dialysis. So the definition of intra-abdominal hypertension is a pressure of more than 14 centimeters. And if you've got compartment syndrome, it's that pressure with new organ failure. So this can be measured either directly through the bladder or indirectly via manometer as a chronic PD. So you put the bladder transducer in the bladder, and then you measure it in that way. There's not been much studies on this, but these are the one study showing the intra-abdominal pressures using the kind of full volumes that we use, and you can see they're all within normal limits. We've actually done some work at Red Cross showing actually slightly higher intra-abdominal pressures than this, but obviously depends on the patients that you're treating. But all actually also within the average, within acceptable limits. But I have on occasion actually reduced the full volume based on the intra-abdominal pressure. So I do tend to measure it once I've done the full volume. I measure the intra-abdominal pressure, and then I use it like that. So if you have raised abdominal pressure, you can decrease the full volume incrementally by 5 mils per kilogram. Important to monitor ventilation. So if you have pressure ventilation, you can monitor the minute volume. And you can use the intraperitoneal pressure to guide for the full volumes. Remember to put the patient in a 30 degrees head up position if you have this problem. Hyperglycemia, you can try and reduce the glucose if you have a problem. If it's more than 20 millimoles per liter, and then we will often start an insulin infusion. And in the guidelines, there's also some some recipes for adding insulin to the PD bags. We don't use this, that we tend to go straight for the insulin infusion if we need to. What about loss of protein? So remember, this is a chronic nutrition guidelines for pediatrics, and you can see that there's actually 0.3 grams per kilogram per day are lost via PD. So that's actually quite a lot when you think treating someone with maybe 1 gram per kilogram per day, a child. You need to actually replace the protein that is lost back into the child. Low birth, what about low birth weight and very low birth weight babies? So these patients are almost impossible to get big intravenous access to do CVVH. But at this stage, the prescription and access is uncertain. In this article by Bergmeyer, they actually summarized all the current literature on extremely and low birth weight infants. So we're talking about babies who are like 1 kilogram here. And at the end of it, there is a number of things have been used. So Cook catheters, the multi-purpose Cook catheters, even Tenkoff catheters are being used in these small babies, or otherwise vascular catheters using side holes, or otherwise even umbilical catheters. What sort of prescription to use is a bit uncertain, but probably similar to what we recommend at the moment. And I would say the Cook catheters are probably a very good choice in these situations. Either the Cook PD catheter or the small multi-purpose Cook catheters are actually good, and we've done this in these small babies. But there needs to be further research in this group of patients. Thank you very much, and that's all I have to say. Yeah.
Thanks very much, Pete, as always, and congratulations on a fantastic set of guidelines which you've produced. They're incredibly helpful. I'm going to talk about the guidelines for adults, and a lot of it will be similar to what Pete's been talking about, but just to go through what's changed from the guidelines that we produced in 2015 through to the update that we've done now in 2020. So the questions the guidelines asked was, is PD a suitable modality for treating AKI? What's the optimal access and fluid delivery modality for PD? Which fluids should we be using, and what do you do if it's not available? And which fluids, and how do we dose PD for AKI? So in terms of how suitable it is, in the first guidelines, we had a 1B recommendation. So a strong recommendation with a reasonable amount of evidence that PDB should be considered a suitable modality. And when we looked at the data again in 2020, we found the same recommendation that we can use it in all settings. And again, a 1B recommendation, although there's slightly more evidence to back that up, but we still haven't got to 1A. And we need a multi-center randomized trial to compare acute PD with other modes of therapy. But I'll talk through some of the studies now. So what are the advantages of PD for AKI? Well, it needs minimal infrastructure, especially water and electricity. And I'm sure all of you know the hassles that we have with getting water running. Half in our dialysis units go down because we don't have steam. So certainly it is helpful in those settings. It's cardiovascularly stable, and as Mignon said, in patients who are cardiovascularly unstable, it's our choice of modality of CRRT is not available over IHD. You've got your own biocompatible membrane, which might be good. You've got large pores to clear cytokines so the patients are septic. And in pediatrics, as well as with COVID, it avoids vascular access and the need for anticoagulation. If you've got someone who's got a head injury or raised intracranial pressure, you're much less likely to get disequilibrium and raised intracerebral pressure with that. And there's some evidence of more rapid recovery of renal function. And this comes from two studies. The first one from Brazil, which I'll talk about later as well, where they randomized patients to high volume PD or daily hemodialysis on the ICU. And the second study below, which was from Saudi Arabia, where they randomized patients to CVVHDF and those that were getting APD with about 25 liters per day. But you can see that the resolution of acute kidney injury was about 3 days shorter in both the Brazilian study as well as in the Saudi Arabian study. What about trials looking at outcomes? This is a systematic review that was done by Dina Cruz and Fred Finkelstein. And you can see that when they looked at both the cohort studies as well as the randomized controlled trials, there appeared to be little difference between PD with extracorporeal therapies. And this is just going back to that Brazilian study. So these were patients on ICU, randomized either to daily hemodialysis or acute PD. And you can see that survival was no different statistically between the two groups. And then this is the study out of Saudi Arabia, where there were 125 patients randomized to CVVHDF or tidal PD. And the other thing that they did is they used biocompatible solutions, so bicarbonate-based solutions, so slightly different to what has been done in other trials. The CVVHDF, they did achieve 23 mils per kilo per hour, which is what we would expect on an ICU as the norm and in a desired effluent dose. And they showed, as I said, shorter time to recovery of renal function, but there was also no significant difference in survival. If anything, there was a trend towards better survival in the PD group compared to the CRRT group. But remember, this is a single center study, so we need to take that into account. So, and just to, sometimes people say, well, acute PD is fine if you're doing it on the wards, but what about in the ICU? So these are the 5 of the big studies looking in ICU patients, but the 3 that are highlighted are the ones where they randomized studies compared to other extracorporeal therapies. And you can see that the number of patients are ventilated anywhere between 65 and 85% of the patients, very high Apache 2 scores, and yet outcomes are equivalent between the two groups. So we felt that it was a suitable modality, but also there's a Cochrane review looking at it as well, and they came up with the same recommendation that based on moderate levels of evidence for mortality or recovery of kidney function, there's probably a little difference between PD and extracorporeal therapies for treating AKI. So you can be reassured that if you are doing acute PD, you're doing a reasonable treatment. What about real world data? Well, I must thank all of you from the Saving Young Lives program who had submitted data to the database. This is the REDCap database, which we closed up earlier this year. You can see more than 400 patients have been submitted to that, but we know that there's an extra 100 patients who've been published elsewhere. And the mean age of patients was 9.5 years, but that spread up to patients over the age of 63. And the median age was 7 years old. So mostly pediatric patients. Duration of dialysis was about 10 days for most of these children. And you can see a 60% survival to discharge, which I think is a fantastic result for acutely ill patients, often presenting late, often presenting in a low resource environment. So really acute PD does work in all settings. And when you look at those that survived, the vast majority of them survived with complete recovery of renal function at the end. So the outcomes really are good. So what's optimal access and fluid delivery? Pete's talked about this quite a lot in adults. We also recommend a flexible PD catheter should be used if you can, and that's what we call optimal. You'll see that in the guidelines is a minimum standard, and that's what we recommend. If you don't have a flexible PD catheter available, you can use one of these other options of catheters like a chest drain, a nasogastric tube. But if you can get your hands on a flexible PD catheter like a Tenkov, obviously that's ideal. We recommend that catheters be tunneled in adults, not so much in pediatrics, but in adults it is easier to manage them if they're tunneled. We recommend that nephrologists are trained to put PD catheters in. It's vital if you're going to run an acute PD service that the nephrologist can do it, because often it's very difficult to get these patients into theatre. The anesthetists tend to turn the patients down because they're hyperkalemic, but also there's often a bottleneck in theatre. So ideally, if you can put the catheters in at the bedside, that is optimal. We also recommend, but with a low grade recommendation, that you use ultrasound. It is helpful if you have ultrasound to use that when putting in a PD catheter, but it's not a necessity. We recommend a closed delivery system. So in other words, using closed bags with a closed connection system. But if you don't have those available, you can, as Pete showed you, use a three-way tap and a spike. Just be careful that you don't introduce infection. And the fewer spikes you do, the less likely you are to create that. And if you have got APD machines, certainly you can use them. It doesn't appear to be any significant difference in outcomes, but if you're doing fewer connections, maybe you are more likely to prevent peritonitis, but there's no data on that. What fluids should be used and what do we do when it's not available? So we do recommend that you use commercially prepared solutions, but we know that many of you can't get solutions or the solutions have expired. So if that's not available, then mixing your own solutions certainly is an option. And we've got a 1C recommendation on that now, which is an improvement from the previous guidelines. As Pete says, potassium levels often fall very quickly. If you've had a patient who's doing acute PD with rapid cycles, after 24 hours, their potassiums often are going low. And so what you want to do is you want to add potassium to the bags so that you maintain a potassium of 4 millimoles per liter. And the reason is that you're dialyzing these patients against that potassium. So you're not going to be giving them potassium, but what you'll do is you'll maintain a potassium of around about 4 due to the diffusion gradient. You should measure the potassium levels daily if you can, but if you don't have that option, then adding potassium after 24 hours is ideal. This is in adults, as Pete said. In pediatrics, they would do it after 12 hours. So this is just to remind you again of the different solutions. So Hartmann solution, Ringer's lactate, and Plasmolite B. And you can see that they have very similar constituents compared to our typical commercially produced solutions. The only difference really being is that there's potassium in these solutions, which you don't get in the commercial solutions, but the buffer is pretty much the same. And then finally, the osmolality is obviously significantly higher in the PD fluids, not in the intravenous solutions. So how do we go about increasing that? Well, we add dextrose to the solutions, and this is all in the guidelines. There's a recipe as to how you can make up these solutions yourself. But the easiest is typically to use Ringer's lactate, Plasmolite, or Hartmann's. And if you add 30 mils of 50% dextrose, you'll get a 1.5% solution. If you add 90 mils, you get a 4.5% solution. So very easy to make it up. This is from Francis Lallier in Benin. You can see here how he's mixed up his solution using Ringer's lactate, glucose, and a three-way tap to save a life. We were worried that if we recommended that you mixed your own solutions, that peritonitis would be a problem. I'm glad to say that if you do it carefully, it doesn't appear to be. And this is from the Saving Young Lives sites in Bingo in Cameroon. And they looked at commercial solutions, which were used in the first stage of their Saving Young Lives program. And then they started making their own solutions using Ringer's lactate and dextrose. And you can see peritonitis rates were no different between the two groups. So subsequent studies, one from Mignon and Peter from Cape Town, where they showed that when they looked at their patients that used mixed solutions, only 2 out of the 49 patients developed peritonitis. which is a low number in what we see in commercial solutions. And also Dr. Ngoy from DRC, who's hopefully on this call today, they also had a peritonitis rate of 2 in 32 patients. So it seems that if you don't have commercially produced solutions, certainly you can mix up the solutions yourself. But we would recommend that you use the commercial solutions because they're much less likely to get contaminated if it's not being done carefully. Also in adults, it's more difficult when you've got 1 liter Ringer's lactate solutions to actually mix it up so that you're giving the patients enough fluid. How do we dose PD for AKI? In 2015, we came up with a recommendation, which was a 1B recommendation, that we should be targeting a weekly KT over V of 3.5. KT over V is basically urea clearance over time. And the target of 3.5 came from the Brazilian study because it's the only study that had outcome data. We were concerned, though, because of the high volumes of fluid that we needed, that maybe we were aiming too high with that and we wouldn't be able to achieve it in a low resource setting. And looking at extrapolating from the CRRT studies and the in ICU, they averaged a weekly KTV of around 2.1. So we suggested that that might be a possibility, but it was only a 2D recommendation. It was an opinion-based recommendation. Well, I'm glad to say that in the 2020 guidelines, we can actually change that now. And so we still say that if you could target 3.5, and aiming higher certainly doesn't seem to gain you anything. But actually, in most patients, a KTV of 2.2 is suitable, or from the Saudi studies that if you're using 25 liters on APD, 25 liters a day, then you get equivalent outcomes. So it seems like you can actually aim a lot lower. Cycle times are really dictated by your circumstances. So short cycle times are going to help you with hyperkalemia, fluid overload, and acidosis. But once that's corrected, then you want to extend your cycle times to remove big molecules and also reduce your fluid that you're using. And the concentration of dextrose should be adjusted depending on how fluid overloaded the patients are. And generally start with higher concentration glucose to make sure that the patients don't become fluid overloaded. This is just from the Brazilian study. So you can see that they achieved a KTOV of 3.85, but they were using 36 to 44 liters a day. Whereas the study out of Thailand done by Watanyu Parpabun, where they actually used our 2 targets from the guidelines in 2015. So they randomized patients to either intensive or minimal, which were the 2 targets. And you can see they achieved a KTV of 3.3 or 2.26. And survival was no different, if anything, slightly better in the minimal group compared to the intensive group, and no difference in terms of their metabolic parameters. They went on to do a small study, and this is the integrity of the study is, it was not integrity, but just it's not a great study, but they did look at using the lower dosage of PD compared to their HD patients, and then their propensity score matched them. So they had 56 versus 28 patients in their propensity scored matched groups. And you can see that there wasn't any difference in outcomes between low volume PD and conventional IHD, no difference in dialysis dependence and no difference in ICU length of stay. So it seems like targeting that lower KT/V of 2.1 would be a reasonable option. So how do we do this? Well, Fred Finkelstein, along with Chang and Claudia Ronco, put together this mathematical modeling for acute PD. And I'm just going to jump out of my screen and take you to an Excel spreadsheet. And if you look at that paper in the supplementary material, there's an Excel spreadsheet that you can actually use to try and work out your dosing. So if we take, for example, this is a 55-year-old lady, we say that she weighs 88 kgs. What it'll do is it'll tell you if you're going to look at dwell time of 2 hours, then you need a dwell volume of about 0.5 liters. 1.3 liters, sorry, I hadn't pushed enter. If you're doing 2-hourly cycles. Otherwise, what you can do is if you drop the volume out and drop that down, they can also work out what volume of dwell fluid you need so what time you need using different dwell volumes. So that's a very handy tool. As with all of these tools, there are issues with mathematical modeling, and this doesn't take into account necessarily the draining in, draining out time, but certainly it's a good option if you want to use it to calculate dwell times or volumes that you can use in patients. Otherwise, in the guidelines, there is a flow diagram here. And this is, again, what are we going to do? So does the patient need dialysis? If they're hyperkalemic, acidotic, or have pulmonary edema, we're going to start dialysis. Do we use a flexible catheter? Remember, blue is what we call optimal. Orange is the minimal standard, preferably a flexible catheter rather than a rigid catheter. If they've got shock or liver failure, then you want to use a bicarbonate buffered solution. If they don't, a standard PD solution. If you haven't got either of those, you're going to mix your own solutions. And then if they're less than 60 kgs, 1500 mils for 2 hours cycles, 60 to 80, 2 liters for 2 hours. And if they're larger, 80 to 100 kgs, you're going to use a slightly smaller cycle time. You want to correct the hyperkalemia, acidosis, and fluid overload. If it's corrected, then you can go to longer dwells, which is here. If not, you keep doing those 2 hourly cycles until you achieve that. As Pete said, in the guidelines, we have got some troubleshooting. So peritonitis, as Pete mentioned, certainly using leukocyte test strips for dipsticks. If it's got more than 2 classes of leukocytes, it's worth sending it off to see if they've got a peritonitis. Let the fluid dwell for 2 hours before you send it, and you send off an MCNS. Dose it as per the ISPD guidelines. And in the ISPD guidelines, which are freely available, there's this lovely table. You can look at what dose to use. And I would prefer that you use the continuous dosing. So you put it in every bag that you're using. The reason being, if with the rapid cycling, if you use it in just 1 bag a day, you may not achieve high enough peritoneal levels in your rapid cycling. So try and use it in each bag. And as Pete said, beware of fungal peritonitis in the ICU patients. If the catheter's not working, it's likely that the patient's constipated. Usually they're critically ill, so they tend to be constipated. But it could be that the catheter's kinked, there's fibrin in it, the mentum's wrapped around it, or it's migrated. An abdominal X-ray is going to be helpful in distinguishing the cause of this. If they're constipated or if the catheter's migrated, using a sachet of some sort of bowel preparation solution like Picoprep will often sort it out. If there's fibrin, flushing it with saline. Try not to aspirate too hard on it, just because you might suck something up the catheter, but giving a vigorous flush will often clear it. And if it's really blocked, putting TPA down can unblock it. You may, however, need to reposition it with a guide wire or replace it over a guide wire. If there's a leak, try and keep the patients, or either way, try and keep the patients on bed rest when the abdomen's full to prevent a leak. But if it happens, try and rest them for 24 hours if their biochemistry will allow. You can lower the volumes if you need to carry on dialyzing them. And you might want to put a purse string suture around the catheter or use tissue glue. So that's really the adult guidelines which I've gone through, and hopefully all through these talks lead into the breakout groups that we're going to do now. So you're going to automatically be divided into groups. You will, if you just stay online, you will be moved into a group, and you'll have 2 facilitators from the Saving Young Lives program. And we're going to go through cases and talk through them, both adult and pediatric cases. I hope this will be really, really beneficial for you and for us. We often learn more from you than you from us, but it'll be great to be able to chat. Please don't go log out whilst you're in one of those groups, because you may not be able to get back into the group. And when you finished at the end, you'll be brought back into the main room. We will just close over the last 10 minutes. So thanks very much.
So I think we're all back together again. We have just about a minute or two before we close. So I'd like to thank everybody for participating, the three lecturers, Minion, Peter, and Brett, for excellent talks. The workshops were really excellent, I thought. The cases were terrific, and they were very informative. So again, I'd like to thank everyone for their participation. I think it'd be wonderful if we could all sort of keep in touch as we sort of go forward. If there are questions that come up, please feel free to email any of the participants. And it'd be nice to keep the dialogue going as we continue to expand and optimize treatment for AKI and expand peritoneal dialysis. Brett, do you want to make any other further comments before we close?
No, thanks, Fred. And thanks for everybody for taking the time to come to the meeting. Thanks again to the speakers. And as Fred says, as Saving Young Lives, we want to be there to support you. You're in very difficult situations, often treating these kids, and it's nice to have a friend to ask. So at any point, if you want advice or anything, please feel free to contact us. We're very happy to help. So thanks very much for joining us.
One last thing, we had a question. Can we share the slides with people?
Yes, certainly. I'll chat to Monica and see if we can get those out. And maybe what we'll do is put it on the Saving Young Lives website. So if you Google Saving Young Lives, you should hopefully be able to get it as well.
Can I also just say thank you very much to Fred? It was your idea to do this as a first virtual. So yeah. I thought it went really well. And thanks to all the tutors. It was really a lot of fun, and to everybody for joining us, because without students, it can't happen. And thank you also to the ISN organizers. I thought it was really slick.
Yeah.
Monica's done a fantastic job putting us all together, emailing everyone, keeping us in check. So thank you very much.
My concern was that if we had a bit of time, I'm sure the discussion would have been quite deep.
Yes.
So probably subsequently we should consider that. Yeah.
Yeah, I agree.
But hopefully we can continue the discussions online. I think that would be terrific. So again, thanks everybody. Enjoy the rest of the day. Thank you.
Okay.
Thank you too. Thank you so much.